Sorry, y'all, I kind of started recording that late, so I apologize. Still, the skeleton gives us our recognizable human form. If we didn't have our 206 bones, we'd just be a big glob. We would just look like jelly. I guess Play-Doh really has a form. I think jelly is kind of our better thing. We have our axial skeleton, appendicular skeleton, and our pelvis. Those are, just remember the 206. That is very important because later on, even throughout life, you will take several classes and they talk about how many bones that the body has, and why. Does, who has more? Is there a particular chance that anybody has more than the other? And yes, there are sometimes that people are born with more bones than the other, or they just don't fuse together during childbirth. Want to click for me. All right, so our axial skeleton. This is the foundation of so our axial skeleton forms longitudinal axis of the body from the skull to the coccyx. So our coccyx part of your tailbone is the very end that sits right there at the crack of your butt. That is the coccyx area. This does include the skull, facial bones, thoracic cage, and the vertebrae column. So each one of these areas are considered into our 206, but they're broke down into many different areas. One has more bones than the other, and then you got to clean the thoracic area with all the ribs. That's just as important. I'm sure I have a different screen that would pop up, but I don't know where it's at right this second. All right, so let's talk about here. So joints occur whenever bones come in contact. So like your elbow joint, your knuckle joints, your finger joints, all that stuff creates different joints. Ligaments are fibrous tissues that connect to the bone from bone to bone, and that helps stabilize the joint. So you have all the fibers that go to your fingers from your finger knuckles, your elbows to the top and to the tibia, to the radius and ulna. Sorry, I forgot my bones there. So all these fibers help join those and gives more stability so it's not shaking and moving around. So cartilage is the semi-rigid and flexible tissue that covers and cushions the ends of the articulating bones. So it's like when you pop your fingers or you sit here, and those are popping the air bubbles that are between your cartilage. And some people say it's not good. Some people say it's bad. I don't know. It's just, it can cause arthritis. We're all grown adults. And you can, my opinion, you can pop it if you want, and pop it if you don't. That's that. So tendons attached to the bone muscles. The bone ends of a joint are held together by fibrous sacs called the joint capsule. Articular cartilage allows the end of bones to glide easy. So instead of just having bone to bone, we put cartilage through there, and basically it helps, it lubes the joint, so there's not bone to bone, and you don't hear that grinding or that it catch if it hits too hard. The synovial membrane is the inner lining of the joint capsule, which is important. This does produce synovial fluid, which at the ends of the bones glide to each other. So again, we have a self-lubricating area in our joints that produces these synovial fluid, which is, I mean, that's very important again, because we don't have every one of our joints, our elbows, we have the ball and socket, we have tissue to tissue. I mean, it's neat to how the body just works and it makes these things happen, and we really don't have to worry about it. It's an automatic response that the body just produces these things. So we have two types of joints. We have the ball and socket joint, which this does allow for rotation and bending. So like our shoulder joint is a ball and socket. A hinge joint, motion is restricted to flexion, bending, and extension and straightening. So this is every time we do this is flexing, we extend it. So that's more of the hinge joint, because we can't really do different ways with it. Our shoulders can go round and round and round. We can't really do that to our elbows. It gotta stop just because they're different joints. So those are part of the big things that we want to make sure that you know those two types of joints, the ball and socket, and then the hinge joints. Don't want to change. All right, so here's pictures of it again. These are just ideas. That is not what it looks like, but you can see more of the concave picture here of the shoulder, which is the ball and socket. And then you can see over here of basically how the hinge joint works. It's, again, these are just pictures of here of what it looks like, but it allows you to flex and extend. And this one right here allows for the ball and socket for the rotary motion like that. Blurred bother you guys in the picture? I don't know. It kind of looks like it's when I make certain movements that it catches. I don't know if that bothers y'all or not. I was just adding something different. It bothers y'all. Let me know about that. I'm actually trying to get a picture of the outside and put in the background. I just haven't done it yet. All right, so let's talk about the skull. I sat here and colored that picture for you guys today. So it took me a lot of time. No, I'm just kidding. So let's talk about our skull. All right, so the skull is now this is divided into different views. You have your anterior view right here, and you had your inferior view because you're looking up at it. This is where your spinal cord comes out of, the foramen magnum. I would take a picture of this and try your best to memorize this as the best you can. This will help you with your patient assessments. It will help you as you go on through more of the medical side of the world. You can probably Google pictures of this. I'm sorry, y'all. 4 o'clock was a long time ago. Because you're going to want to know where different parts of the face are and what 14 bones make up the facial bones. All right, so in the cranium, you have four big bones that consist of protecting the brain. All right, so you have your occiput. Ooh, that just messed me up right there. Here's your occiput right here. Then this is the temporal bones. This is the lateral portion. Here's your temporal on the side of your face. As everybody knows, we rub our temporals. Sometimes we get headaches. You have your parietal bone, which is located between the temporal bones and the occiput. So this is going to be right into here. And then you have your frontal bone, which is your forehead. Those are the main ones that kind of protect I'm sorry, here's your parietal bone. I apologize about that. It goes and connects the temporals to right here. So again, memorizing of this would be very important. The facial bones do consist of 14 bones. They have the upper non-movable jawbone, which is right here. This portion in yellow does not move, or it's not supposed to move unless there's been a severe amount of force could cause that to break. Your maximal or your mandible down here is what moves. It goes up and down. As we talk, the mandible has a hinge and it moves back and forth. You have your cheekbones, which is your zygomite bones, one on each side. Those also, I've seen those fractured and broken before. We talked about the mandible. We talked about the orbits and the very short bones from that bridge the nose. So these right here, the nasal bones, those are commonly broken. We've seen like boxers, fighters, MMA guys that get into fights and are broken. It's like 66 degrees in here. So yes, I'm being a little girl and covering up in my blanket. You have to excuse me. I think it was 66. It's like 62, 65 in here. It's cold. We're supposed to have 55-degree weather out here next week. It's gonna be freezing out here in this place. So knowing these helps you understand like a maximal fracture. Right in here, if one of this is broken or fractured at all, you can have some space that's going into the brain. You have to be very careful when you go to orally intubate somebody. You can't nasally intubate somebody in certain cases. Like if there's a fracture up in here, you may cause the nasal airway to go into the brain. So knowing that the maximal, or being able to see and know that that is the maximal bone that is broken, can potentially cause some other issues as you go into your patient assessment. And knowing that is how to provide proper ventilation so that you're able to, I can put them on the bag or put them on the right amount of flow for oxygen. All right, so here's your axial skeleton. Your spinal cord is composed of 33 bones. It's divided into 5 sections. That is probably going to be a test question. The vertebrae in each section are numbered from the top to bottom. The cervical spine, the neck has 7 vertebrae. The thoracic spine, which is the upper back, has 1 pair of ribs attached to each of the 12 vertebrae. So as you can see right in here, these are your ribs as they come through here. I'll teach you a secret in just a second, so to help you later on. The lumbar of the lower back has 5 vertebrae. So here's a little trick. So L4 and 5, which is your lumbar, it helps keep the diaphragm, which is what pushes up and makes you breathe in and out. If the diaphragm is the L4 and 5 fractures or separations, most of the time the patient's going to die because that does not allow the diaphragm to contract and relax. So if you know that there's a fracture on the L4 and 5 due to the mechanism of injury or the MOI, you may be able to say, oh, we need to hurry up because I'm going to have to bag this person, or I'm going to have to get a paramedic here quickly because we're going to have to stick a tube down their throat because they're going to die. And then you have your sacrum, and then you have your coccyx. Like I told you, here's your coccyx right down here, just right at the right here at the crack of your buttocks. And then you have your sacral right in here. You can break this, and this is one of the few bones that's out there that you can't really do anything about once it's broken. It's always going to be broken. Anybody need to write anything down? Y'all good? I'm able to move on. Great. Try to pay attention. Come on. Notes over here. All right, so we're going to talk about your thoracic. Your thoracic cavity contains your heart, lungs, esophagus, and great vessels. So your lungs are going to be on these sides. Can y'all see my cursor as I'm moving around the screen, just to make sure?
Yeah.
Perfect. So your lungs are going to be on each side right in here. Your heart's going to be up into around the 2, 3, and 4 vertebrae. Your great vessels are in the same area. And then your midline of the chest which is your sternum. This is where it's going to be right here. So this is the body of your sternum, your xiphoid process. So when you're all learning CPR, you know that's where you went 2 fingers below the xiphoid process. That is it. You can't on me since I'm healthy. I'm thick. But some of your children, smaller kids, when they take deep breaths, you can feel that V very well. And if you push around, you can kind of find the xiphoid process. I'm not trying to say push hard because it can get very painful, but you'll be able to identify the area. Here's your 12 set of ribs. Your clavicle is right here. Any one of these that you break are very painful. Here's your floating ribs are number 12, but knowing rib placement, you're able to palpate those ribs, which palpate means I'm feeling for them, gives you an idea. I know everybody's seen on TV where they take and put the needle in the chest or right underneath the arm. So here's what we're doing. So when I put the needle in the chest, below the third, on top of the third intercostal rib, I'm aiming for the top part of the lung because I want to let the pneumo, which is, remember, pneumo is air. So I'm going to let the pneumothorax, because air is not supposed to be in that area. So I'm going to let that out. So if I go underneath the arm, I'm going between the bottom of the 6th, top of the 7th, and I'm trying to do the same thing as trying to let the pneumo and hemo out at that point, because I can let blood out from that area too. So those are the 2 spots that you would, well, paramedics and higher would put the needle that goes in here to let between the 2 and 3 and the 6 and 7. Just adding a little bit of tidbit of information. Try to make some of the things we talk about in here tonight a little bit more interesting. And I'm having to adjust my screen on 2 different screens here. All right, so the arms and legs, we talk about their connection points, the pelvics. You have what joints are certain where. You need to be able to identify what, do you have a hinge joint or a ball and socket joint between your legs and your pelvic area, your upper extremities, your pelvis, your lower extremities. What type of joints do you have where? You can be able to tell when you go to isolate an injury, if you go to stabilize it, you go to rapid or minimize any type of movement, you can help do that knowing which type of joint is in the area. Because if you pad it up into a certain way and then they try to move their arm or their leg, it can possibly go one direction or the other. So you need to try to figure out, do I need to stabilize the whole hip or do I need to stabilize just the knee down? Well, the knee down, knee and hip are 2 different types of bone or joints. So that may be beneficial to you to know which one's which or where they're located at. So we talk about our upper extremities. This extends from the pectoral griddle up in here, all the way down to the fingertips. So that's more of your upper extremities, your right and left upper extremity. So you need to know which bones. You have your radius and your ulna into your arms, and then you have your phalanges, which covers your fingers, and then all the different types of hand bones. I don't expect you to know the name of the hand bone, the bones that are in the hand. Those are important, but at the same time is let's just identify how many bones are in the area. Let's see here. Now we're going to talk about our clavicle. We'll talk about the different types of bones that are in that area, the joints. So this is your shoulder griddle right here. Shoulder griddle. This includes your clavicle. Here's your scapula that's on the back side of the shoulder. I don't know how many hunters are in here, but any type that you, let's say if you skin a deer, you've seen this clavicle on your deer's front shoulders. You can see the different types of joints that they also have. It is kind of neat. I know at the same time, some people are just kind of sickened by that. And I completely get it. We're not going into detail, but it's able to identify the different types of bones and joints and sockets that's in there. So again, your clavicle, that is a very, very painful bone to break. I've seen one due to a motor vehicle accident, and I saw another one due to a guy running down the road with an 18-wheeler battery on his shoulder, and he slipped, and the battery landed, I guess it went up and went back on his shoulder, and it broke his clavicle. I don't know, but you know how that is. So your humerus is your upper up arm here. These are your humerus points. Your radius and ulna are down here. Again, your scapula and your clavicle. I mean, everybody can feel their clavicle bone, so you know where that's at. And your sternum, your joint right in here. That's not, it's considered a joint, but it doesn't hinge. It doesn't have a ball joint. So it's this sternoclavicle joint. Just the proximity, the location is the importance. Let's talk about the arm, which we know. So we have our humerus, our radius, and ulna. Knowing the location of those for your radius and ulna are going to be important. So I would write that down. Your radius is on the lateral side, which means, somebody tell me where's the lateral side at? Tell me where's the radial, where lateral and medial side. Somebody tell me what that is. I flip back to your notes. I know y'all took notes. Call on somebody.
So the lateral side is the outer side of the body, if I'm not mistaken, the right way. And then the radius side is the is like the bone surface or whatever like that.
So think about midline and outside. You just gotta think of the difference. If we don't have a picture because they don't want to show us a picture, but think about the lateral, which is the outside.
The outside for like the outside of the outside of the body. So Got you. Okay.
So good job there.
I'm trying, man. I'm trying, man.
Keep it up, brother. Keep it up. All right, so let's talk about the hand. This is where it gets really important. The hand is what's going to happen. We will start talking about all the different bones here in the hand because you need to know what the correct name of the fingers. Your thumb, your index, your long finger, your ring finger, and the small finger. We all have ring fingers, and we all have long fingers. I'm sure nobody's ever used a long finger at least once in their life. But they're all considered phalanges. And then the mid part of your hand is your metacarpals. Those can get fractured. You can crush them. You have your carpals. So you ever hear a carpal tunnel? The carpal tunnel sets part right around in here where your joint is, and then your radius and ulna kind of go into tacks there. So we talk about the carpals, metacarpals, the phalanges, which again, from the knuckle up are all called phalanges. What they say. I'll listen to them. They're the ones who write the book. So the pelvic griddle consists of the two large hip bones, the coccyx, the sacrum, and the coccyx. Each coxa is formed by fusion of ilium, ischium, and the pubis. Tongue twister. You don't say that one pretty fast. It's making my cup blurred. That's a lot. So y'all understand this chapter's pretty big. I'm not gonna lie to y'all. It's a lot of information. So be careful and be ready for it. It's a big test. So let's talk about the pelvic. So this is where we start talking about to where the arteries, inferior vena cava comes into place. Your descending aorta. So this is considered your femoral right here, femoral artery, and your femoral vein. So they are actually deep when you go to check them. So understand this is pretty thick. It's pretty deep inside the body. So if we go to palpate this, it's easier. So if this is my legs right here, it's easier if we spread the leg apart and we push down onto the pelvic griddle. Because it's hard, I mean, it's deep to feel, and you have to push real hard with your finger to be able to get that. I wish I had a mannequin here, I would show you, but our mannequin's outside. The time when your pelvic break, your pelvic will break right here. It is very painful. You can get some breaks. This is a high break. You can get breaks in here. Putting your feet on the dash in a car wreck, you can destroy your pelvic area. Knowing that your femoral artery and your femoral vein, there's reason why that they put them in different colors. One is coming from the heart and the other one is going back to the heart. And the placement of the different bones. This is your coccyx, remember that's your butt. So these are all important. I mean, every part of that diagram is important, y'all. Knowing which one's which. I don't remember if the test has pictures. I know that National Registry does not, but they may ask you certain, like where's the sacrum located in the pelvic area? Where's the sacrum bone? And you're like, it's sacrum, so it's got to be sacred to the heart. I promise you, it's going to confuse you. But just knowing the placement of your bones, I don't expect you to know every single bone that's out there, but identifying your bigger bones is what's going to be the most important part. Obviously, now we talk about your longest bone in the body. The femoral head connects to the pelvic griddle by a ball and socket. The greater and lesser transchester serves as an anchor point and major muscles to the thigh. Stand by. So that's what ties it in. They're bad at pictures. Like when we want some good pictures, they won't put them in here. Then they put pictures in there of stuff we don't really want. So knowing that the femur is anchored to the hip by a ball and joint, and if we can go back one page, so right in here is where your femur connects to that ball and socket. And it's got a head and a long bone. That's the longest bone in the body. It's the femur. Hint, hint, hint. Talk about your knee. The biggest thing to know about that is where your patella is. Patella is considered the kneecap itself. And then we're going to talk about the tibia and fibula. This is the anterior of the leg, shin bone. And then your fibula is the lateral side of the leg. Should be able to feel those, each one of those on yourself. That's not something that's really going to take a lot of palpating, pushing around to try to feel that. So those will be able to be rapidly identified. Get my slides caught up here on this side. All right, so our ankle joint. The foot comprises of, there's a picture coming up, so don't, we'll just look. So we'll have it's the same thing in the hand. These are the same muscles, same bones that are identified here, your phalanges, and then your metatarsals. And then you have your heel bone, which is your calcaneus. Now, I'll tell you some hint. This right here is where plantar fasciitis takes place. Right there, I've had it. On one foot, I've had too many shots in it. The other foot, I've had it cut. A lot. Knowing that there are 7 tarsals and 5 metatarsals. But does contain 12 bones, and exactly how they're divided is important. All right, so let's talk about your skeletal system. What does it do? Your skeletal gives us shape. It gives us a rigid structure to attach to. It provides protection because of the bones to our organs, to our spinal cord, to our eyes, our brain. So it provides a lot of protection. It does allow for us to move because the different types of joints, the ball and joints that are connected to our feet and to our legs, it helps us move. It does store calcium into the bones, and it helps create blood cells. So we know that that's where they come from. I found out that my body makes too many red blood cells, so I have to donate blood regular. And then I have to do platelets because somehow or another I make too many platelets. Turning 40 was rough. Everything started happening at 40. The body just said, I'm gonna do what I want to do. All right, so the musculoskeletal system. So what does it do? What does our muscles do for us? Gives us posture. Not all of us have the best posture in the world. Sometimes you catch yourself leaning over and you're like, oh, my back hurts. It gives you proper form. It does allow us to attach to our bones. It gives us form. I also say it gives us structure, just like the bones do, because of how it attaches it. If the muscles weren't there, the bones would really just flail around like the plastic ones do when you shake them. The muscles help contract and relax for us to move. And again, it does protect vital organs. So let's say like our stomachs, our internals are protected by our stomachs. Stomach muscles, you have your rib cages, your spinal cord on the backside. So that does give you some protection in there. Some people have more stomach muscles than the other. They're more defined, and I'm not saying that they have better protection, but it's just more rigid. Mine's not. I don't have to worry about that. I have to protect mine pretty hard. Now we're going to talk about the different types of the skeletal muscles. So this is where it gets fun. We know that the skeletal muscle attaches to the bones of the skeleton and forms major mass of the body. The skeletal muscles are known as a voluntary muscle because it is under direct voluntary control of the brain. So the voluntary muscles, the skeletal muscles, they have to be told what to do. So our brain tells them, move, 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 contract. Oh my God, that's hot. Contract it back. All right. So your smooth muscles are considered cardiac movement, cardiac muscles that do not require constant thought of they're involuntary. So what that means is that our cardiac muscles is found in the heart. So this muscle right here, it has all the different anyway, it's more porous. What it does is allows for the heart to just contract, beat and contract without us trying to do anything. The muscles that are with our lungs do the same thing. We breathe involuntary, and our heart beats involuntary. So what that does is it keeps us simple-minded people from having to be like breathe, blink, heartbeat. We don't have to worry about that. And as we know over time, those muscles become weakened. And unfortunately, that's how some patients go into cardiac arrest, respiratory failure, is just tired. They've done all they can do, and not saying that they're just like, oh, you're going to be tired, your muscles are going to stop, you're going to die. Well, no, they can do open heart surgery, they can do heart replacements. As you just saw here recently, they had a full heart transplant from a pig to a human. There's different options out there. You can strengthen your cardiac muscles, your skeletal and your smooth muscles by exercising, proper food, proper health. All those can be done to improve things within the body. We're going to talk about, so here's the major muscle groups. We talk about pectoral muscles, deltoids. These are more, and I'll say they're very important to the people that work out. The bodybuilders, you want to know, like when you go to the gym, you want to work your different muscle groups. You don't want to work your upper body only. You want to try to alternate it. So it just divides it up into the different muscle groups. So you can see here that we all, male and female, still have the same muscle groups. As a matter of the makeup of the body, they're in the same exact place. Both male and female have gluteus muscles. Your quadriceps, your quads, your bis, your pecs, your deltoids, they're all the same. We all have those, which is a blessing, so we can all function. Contraction and relaxation of the system makes it possible to move and manipulate the environment. Byproduct of this movement is heat. So when we work out, we move, we go up or down stairs, we produce heat, which makes us sweat. When you get cold, just shivering is an involuntary, which also produces heat. So even though we find somebody that's hypothermia and they're shaking, it's just fine. We're okay with that. Where it gets to the point to where we start to make more worries is when they stop shaking. Their body is past the point of being able to control those involuntary muscles. And now that they're past that, okay, I'm shaking to get warm, I can no longer do that, that now the body is just, it's out of energy, it's out of ability to continue to shake and move forward. Let's see, another function of muscles is to protect the structure underneath them, which we know because we've talked about what it already does now. Let's talk about the upper airway. This is a big chapter, y'all. All right, so we talk about the upper airway and we break it down into the lower airway. So let's identify this. This is your nasopharynx. This is your nasal passage is what is to your nose, and it all goes down. So your nasopharynx, your nasal passage, your pharynx, all this in your mouth, they all move air in and out along with fluids, food. It's just you have your little epiglottis right here, which is your flapper valve. It tells it which way to go. Your larynx, everybody knows that's what makes you talk. So now we're going to talk about that is what's so nasopharynx, nasal airway, the pharynx, the oropharynx, the mouth, and the epiglottis all make up the upper airway. Hint, hint, hint. I would know those so you can decide on which ones help make up the upper airway. So the lower airway is divided by the tracheum, your alveoli, which is broken down into here, And then you have your bronchioles, which is down into the stems. And then you have your main bronchi, which is the bigger part of the airway system. So here's a little tidbit information. When I tube somebody and I put a tube down their throat, I'm entering it in their mouth and I'm going to set it down and it's going to rest right around in here. Now, the reason why that's important is because I need to make sure when I start bagging them with one of our airway devices is that you see equal rise and fall of the chest. If for some odd reason I'm only seeing the right side, I have a right main stem intubation, which means my tube got pushed down into the right stem because the right stem is a little bit higher than the left. So you have a little bit of kilter when you go to do that, so you can't push as far. Now, if you're looking at this picture, you're like, bro, that's a long ways. It is, but our tubes are not like this freaking long, but I mean, they're pretty long. When we get into airway devices, I'll break out some airway tubes, tools, as long as I'm out here, because I don't think I have any at home. All right, so down into the lungs and our base of our lungs, it breaks down over here. So let's look at this picture. You have your bronchioles, which is down into the tube, and then you have your vessels. So your alveoli is sacs. You can get fluid built up into your sacs, which allows for not proper ventilation. Your airway, your tidal volume can be reduced due to the sacs are just full. Heavy smokers, these will be filled with smoke, tobacco, nicotine, all those will be filled into here. And then you'll notice that their respiratory rate and their drive is a little bit harder than others. Even, I tell you, a telltale sign of a heavy past smoker or heavy smoker that has a airway issue is when you see like the clubbed fingernail. Instead of like ours, looks like these, it'll look clubbed. It's kind of at an angle and they're not doing anything about it. Fingernails are a little long. Yes, they do have the yellowness that comes from the nicotine to their fingers, but that's just part of it. You see clubbed fingers, you know that they suffer from some sort of an airway competency issues. It could be because of their alveoli are full over time, and they have to, later in life, they're going to require some sort of oxygen delivery system, which sucks. But again, they knew that when they started smoking, that it's going to cause issues later in life. We talked about this a while ago. Your upper airway includes your nose, your mouth, your tongue, your jaw, your larynx. And again, it divides into your larynx, helps divide the difference between the upper and the lower. So remember from CPR, which I'm sure all of you had, which I hope, is your mandible. You will have to move when you do a head tilt chin lift or a jaw thrust. Your mandible is what you're moving. Yes, your tongue can swell and get in the way and cause a airway complication. But again, we have like a tongue block. We can use those things. Your mouth, your oral cavity, and those are all considered into your airway. So when you say you have an airway compromise, well, like how? Is like the nose blocked? Is the mouth blocked? The tongue swollen, and you can't get it in there? Actually, speaking of a tongue, I actually saw a video the other day where a lady, her tongue was all swollen out of her mouth because she got bit by a brown recluse. She lived, but it was a very disturbing picture. I wasn't prepared for that. Our upper airway is continued by our pharynx, which has your nasopharynx, your oral pharynx, and your laryngopharynx. Good Jesus. You have your trachea and your epiglottis. Knowing the anatomy of that will help you guys out in the long run. Again, if you can look at this picture and be very familiar with what is where and where it divides from the upper airway to the lower airway, the better off you'll be. I'm not expecting you in this class specifically to know down into here to where your alveoli breaks down from your vessels, the blood vessels supplied to the alveoli. I'm not expecting you to know that, but I'm expecting you to know the difference between what it makes up the upper and the lower airway. Those are important because later on, when you go to work on the airway system, knowing the anatomy of those are very important. We'll talk about the lower airway. We have your thyroid cartilage, which is, ladies, you don't have this, but the men, we have our Adam's apple. Cricoid cartilage is immediately below the thyroid cartilage. This is the cricoid membrane that's in here. Your trachea ends at the cornea, which is divided into right and left bronchi leading to the bronchioles, which is the same thing as the right and left main stem. The anatomy of that is broken down, so we can identify on which side of the airway system that it is. Again, I need to know if it's going to be on the right side of the body or the left side, and we can identify that. Is the trachea technically lower airway or upper? The diagram says lower, but the slides say upper. Well, I thought that's what I read. Let's go back and look at that. Oh, I'm sorry, the throat's killing me. I need to. All right, so your trachea is going to be a part of your lower. Your epiglottis is what divides your upper and airway. So again, yes, it is lower airway, not the upper. Andrea, I've tried it, done everything. I feel okay. I just don't feel good. I think it's the drastic change of temperatures out here, and I'm blaming it on testing COVID every single day, but nobody's paying attention to me. They don't listen to me. We talked about that. Where am I at? Trachea. All right. So the trachea, you do have two lungs, which we know that unless you've had some type of respiratory issue that had to, maybe a lung has been removed. So the lungs are held in place by the trachea, the arteries and the veins, the pulmonary ligaments. So your lungs are just, they're part of your airway system that come to your trachea. There's nothing that's really holding them in place. There's no ligaments. There's no fibrous fibrous muscles that hold the lung in place. They just float inside the cavity of the body. Each lung is then divided into lobes. You have your right lung has an upper, middle, and lower lobe, and your left lung just has an upper and lower lobe. That's the reason why your right lung's a little bit bigger. If you were to take an x-ray of it, the right lung does sit bigger than the left side, obviously, because now there's three different types of lobes that are in that lung. If you've ever had the ability to take and cut open a lung, you can see that. I've done it in a cadaver class, and I've done it actually hunting to show my kids. My kids actually know a lot more than they probably should because I teach them a lot. We hunt a pretty good bit, so make sure they know the difference of the muscles, the hearts, and all that. I don't cook them and eat them and all that crazy stuff, but my kids know the difference. Kind of important to me for them to learn. Let's just say each lung is divided into two lobes, which we know that now. With the lobes are the bronchiole and bronchioles, which end in the alveoli. Alveoli allow for a gas exchange where the oxygen and carbon dioxide, it changes it out. Good air for bad air, and our carbon dioxide comes out. So the mechanics of breathing. So we talk about our pleura. Yeah, pleura is the visceral pleura covers the lungs. The pateral pleura lines the chest wall. Say one that's important is a thin layer of fluid between them facilitates movements of the lungs, and the pleural space is a potential space between the two pleura. So what it is it's inside of the cavity of the body, and the lungs, they do rub when they inhale and exhale. Without that, if they didn't have that a substance in there, the lungs can stick to the outside of the cavity, the inside of the cavity of the ribs. Well, you won't be able to breathe, so we need that fluid there, basically, that allows for the lungs to take deep breaths and inhale and exhale. So again, without the, I'll tell you this, So when children are born, males under 31 weeks are most of the time kept in NICU longer than any other child that's born, due to they don't have enough of the pleural fluid that sits in there. A lot of times they'll take and inject it through the nose, and they'll stimulate the child and they'll take a deep breath. It does help, but at the same time is they're kept there longer because their respiratory rate is it's more difficult for them to take deep breaths. African American females and males and little bitty Caucasian girls don't really have that issue. And it's always been like, what, why? And I just, like, I asked those like hard questions of not like, no, it's just because it's always been, but like why? I want to know why. Good friend of mine's a pediatric doctor, and he tried to break down and tell me, and I was like, bruh, I don't know what you just said for the last 21 minutes. I need you to break it down to like dummy level. And he literally said, because that's the way they've always been. For me, that's just the way that I got it. I understood, and there's nothing that we can do prenatal or post-delivery to adjust it. That's the reason why they want little Caucasian males to stay in the womb as long as possible, so that pleural fluid is actually built there. So we go back to the pleural space. So if you have the space between the lungs, if y'all can see here, the space between the lungs and the ribs, this space in here is called the pleural space. That is where your hemothorax or pneumothorax can build, which can compress on the lung and not allow you to take deep breaths. You'll be like, oh, it hurts on this side. I'm having trouble breathing. Probably sound a little worse than me. So that's what we want to remove. We don't want air in the pleural space. Sorry, I fidget, and I apologize for that. Try to keep it low so y'all don't see it. We want to keep the pleural space clear so the lungs can contract and go and not have any type of fluid or blood or air. That's a no-go. We don't want that. All right, so here we start talking about lungs. We break into the how they're held in place. Ooh, there it is. So this is our cricoid cartilage right in here. This breaks into males on the Adam's apple. For the males in the class, what I want you to do is lean, look up. You can find the top part of your Adam's apple. Well, right below it is like you have the little bone, which is right here. A little bit below it is your cricoid membrane. And what I want you to do is apply just a little bit of pressure. I already sound bad, so you're not gonna be able to tell the difference when I do it. Females, you can do the same thing. It's just, you're not gonna find the anatomical position of the Adam's apple. You better find the cricoid space because there's a little gap between your cricoid and your membrane. You'll find the little gap right here. And this is if you push a little bit, you're like, oh, I have trouble breathing. No, at the same time, that's just like we can do in extreme cases, we can do a cut down, stick a tube in there. If you have a lot of facial injuries, we can put a tube there. That's where we aim to shoot it at, or aim to go. And we break it down. Here's our thyroid cartilage. Here's our cryothyroid membrane. So right in here this is what I want to cut. I'm going to put a tube in that way, and we'll cut right there. These are the rings that we look for when we start talking about the larynx and vocal cords. We just have to be very careful. Windpipe. So you have your alveoli. You see right here on the ends, that's where your alveoli are. Break up into here. We talk about the main bronchi. So this is a right main stem intubation. Is if I stuck the tube and it was right here on the tip, this young lady, it would be broken down right there. And then you come down into the smaller bronchi that breaks it down from the main to the smaller bronchi. And then down further, you get into your alveoli. Here's the diaphragm. At that point, it's relaxed. It's trying to take an inhale and exhale. So then when it contracts, it does the same thing. So if you'll notice in this picture also, you have your you have your main, mid, and lower lobes. And you notice over here, there's only two. Tell the difference right there, top and bottom. Just kind of point out some things anatomically so y'all can see them and understand them a little bit better. Let's talk about the diaphragm. The diaphragm is the primary muscle of breathing, which it contains a voluntary and involuntary. We can make ourselves take deep breaths, so we voluntarily control it. But most of the time, it's an involuntary process to where it does it on its own. We don't have to worry about that. You have your cervical muscles, your intercostal muscles, your abdominal muscles, and your pectoral muscles. Some people's are bigger than others in this area. They have better abdominal muscles and better pectoral muscles. I just hide mine for better times, is what I like to tell myself. So our diaphragm and intercostal muscles, they do contract, enlarging thoracic cavity. So when we take a deep breath, we're enlarging that area. Pressure with the thoracic cavity decreases in the lungs field. I take a deep breath, I'm minimizing the pressure that's in there. So when I exhale, the pressure builds up. And that's what causes a negative ventilation. A negative pressure ventilation is when you inhale. Active parts of the respiratory cycle. This is neat right here, how the lungs fill with air, because when I take a deep breath, I'm reversing the pressure outside is higher than what it is on the inside of my body. That's why air rushes in. And again, remember, it's an involuntary cycle. So, you know, sometimes you may be sitting here and you just take a deep breath. Well, that's your body telling you that you're not getting enough air or enough oxygen. So we bump that up. The body, you get those yawns too. That's the body trying to compensate for low carbon monoxide. They off it, or your pulse ox is a little low. You're not satting enough oxygen. So we try to overcompensate that when we yawn or we take deep breaths. I think 90% of mine is I yawn because I talk so much and I'm not breathing as much with oxygen. Not bored. That's what I think. Right or wrong, it's my story. Our diaphragm and intercostal muscles do relax to exhale. Our thoracic cavity returns to its normal shape and volume on exhalation. And we do have passive portion of the respiratory. So it's relaxing. Everything's going back to normal. Okay, it's back to normal. It's time for inhalation. All right, for the respiratory system, let's tell you what, before we dive off into these next slides, let's take a quick break. We'll see y'all in 10 minutes. Been going an hour, so we'll take a break and see you guys back in 10 minutes. All right, let's get back to this. All right, so the respiratory system, the pathophysiology, what I want you to do is just understand the functions that's out there. I'm trying to answer, multitasking. All right, so the respiratory system functions is to provide the body with oxygen and eliminate carbon dioxide. So the point is we got to get rid of it. We know that our body makes the carbon dioxide, but getting rid of it is just part of it. Ventilation and respiratory are two separate yet interdependent functions of the respiratory system. Ventilation is the movement of air between the lungs and the environment. So when we say we ventilate them, we're taking the air from the outside and we're pushing it in. And then as a part of the respiratory system is the exchange of oxygen and carbon dioxide in the alveoli and in the tissue level. So there's two different functions. We need to make sure that you know that when we go to ventilate somebody, that we're doing an air exchange, that we're putting the air from outside to inside, and it's going to be clean air. But at the same time it's clean air. We need to exchange the dirty oxygen because we have 21% oxygen outside, and we use 16% of it. So when we turn around and try to off that other 5%, we're just turning around and pushing it right back out. So our body's taking in 16%, using it, doing the exchange, and then we're going to turn around and off it. Now, off it, and that's what we do now, is we take in the 16%, and we're going to use it. Our body takes it and flushes it all the way down to our system. Now, we're using the clean oxygen. Yes, we're doing exchange every single time that we take an inhalation. We breathe in, we breathe out. But our body's still using the clean oxygen. It pushes it down to different parts of our body to where it good oxygen perfusion. Imagine that. It's not going to work. I tried to fix that when we were off. All right, so the respiration is the exchange of oxygen and carbon dioxide in the alveolar tissues. Probably know that that would be an important one to use. Diffusion is a passive progressive in which molecules move from an area of higher concentration of molecule to an area of lower concentration. So let's talk about that. So respiration provides oxygen to the cells and removes waste of carbon dioxide. So we're diffusion process which molecules move. So we're going to turn around and we want to infuse the body with clean oxygen every single time. Now, it is a slower process, but we want to make sure we remove the, when we breathe, our body, its blood is exchanged, the dirty carbon dioxide, and then our unoxygenated cells go through the heart to the lungs. It gets changed, it's dirty to clean. It's a continuous process. I love the way the heart beats. I think the functionality of the heart to me is one of those, it's just a cool process and how it does. And we ain't got to do nothing about it. We just hang in there. We're hanging on for the ride. So we talk about, why does my slides not equal up on both screens? It's probably operator error. So the brainstem controls breathing, but monitoring levels of carbon monoxide and the dilated and the blood in the spinal cord. Sorry. So our brainstem, which controls all the nerve endings, that's our synapses that comes from the brain. It shoots out and tells us to squeeze, to touch, to talk, to make sounds with our vocal cords to make words. That controls how much oxygen is there. If it's not, we need more. It tells our body that. So breathing is automatically controlled. Breathing is automatically controlled if the level of carbon dioxide or oxygen in the arterial blood is too high or too low. Breathing occurs as the result of a buildup of carbon dioxide in the cerebrospinal fluid, which causes of the pH to decrease. Sorry. The medulla oblongata, see, that was true when they were talking about that water boy. I'm showing the age. Some of y'all probably never seen that. The medulla oblongata stimulates the phrenic nerve, causing the diaphragm to contract. The primary reason of the breathing is to lower carbon dioxide levels not to increase the oxygen levels. You have your hypoxic drive, which is your backup system, controls the respiratory system. It stimulates the breath that comes from the lower oxygen levels. So hypoxic drive is when you get too low of oxygen. Y'all can see my slideshow, right? Something just popped up and said, asked if I wanted to resume it. I don't know what that was. I see it. Maybe y'all can tell me. Take that as a yeah. Yeah, tell me if you couldn't see it. All right, so hypoxic, if you get too low of oxygen, you become hypoxic. So your hypoxic drives when your body automatically recognizes like, oh, we're going into the hypoxic state. There's some reason that we're not breathing right. It's going to kick into that backup drive and try to make you breathe more. It's going to kind of consume more oxygen. So then we're going to go into the nervous system controls breathing. And why? Because we know where it's going to go through, because it's going to go through the spinal cord. All right, so the medulla oblongata is responsible for initiating the ventilation cycle. The primary stimulated by high carbon dioxide levels, and it helps control the rhythm of breathing, initiate inspiration, set the base pattern for respiratory, and send the signals of the diaphragm via the phrenic nerve. So the pons has two areas in which it helps and augment respiration during emotional or physical distress, helps change the depth in inspiration and expiration. So when we're all upset or something traumatic has happened, we get that dump of epinephrine and we get into that fight or flight mode. And then our body does different things, which is the functionality of fight or flight, the dump of epinephrine. You get your ramped up, you get your speed, and then it helps with it's kind of the same thing as when our body realizes that our carbon dioxide is low. You get small doses of that fight or flight. You get, okay, you dump of this. We need to increase the respiratory rate. When it helps augment respiration, so you may start breathing faster because you're upset, you're nervous. It's realizing your body is using more oxygen, so you have to breathe faster to get more in. And it helps to change the depth. So when normal breathing, I'm breathing 16 to 18 times a minute. I'm breathing normal rate and rhythm. But when I get nervous, I get upset, something scares me, all of our respiratory rates kick into overdrive. We're going to go to about 24 to 26 times a minute, and it's going to be a rapid, shallow respiration. So it's a regular, irregular pattern, because it's breathing regularly because it's short rate rhythm, but it's irregular because that's not how we normally breathe. We're not just, we don't normally do that. So that's why we consider it a regular, irregular pattern. So again, back to that, sorry, let me get off of that. I was kind of tantrum there. Understanding that the medulla oblongata initiates the ventilatory cycles, that's probably the most important thing that you need to understand. I'll get off my rant there. I kind of went a little deep, I apologize. All right, so ventilation is just simple movement of air in and out of the lungs. Simple. Amount of air that is moved in and out of the lungs on a single breath, that's considered tidal volume. I would write that one down for sure. Generally 500 milliliters is in an adult. So if everybody has, I hope to God, everybody's seen at least a IV bag in your life. Most of the time, those IV bags are 1,000 mLs, which is 1,000 milliliters. So half of that is generally what we breathe. So if you think about that, that's pretty big. So inspiratory reserve volume is the deepest breath that you can take after a normal breath. So if you can try to breathe out as much as you can, and then when you take that inspiratory reserve, you're trying to breathe in as much oxygen as you can in one breath. The expiratory rate volume is the maximum amount of air you can forcibly breathe out on a normal breath. So that's normal for it. So when we take that, take as much oxygen as you can at one time. That's trying to overload our system, and that's just you're not going to use any more than 16%. But again, we catch ourselves taking those deep breaths, like, or when you yawn, like I'm doing right now. Our body is telling us that our carbon dioxide levels are too high. We need to increase our O2 levels. So we're going to yawn to try to off some of that air. So the residual volume is the gas that's remaining in the lungs after the ventilation, or actually after the exhalation. So knowing what your tidal volume is and what your normal oxygen breath is, about 500 milliliters, you know the tidal volume and what the residual volume is. Now, I can't tell you exactly what is going to be regular, that's regularly left inside the body. I should know that because I had to know it at one time, but normally that's what's left over. There's a normal amount, let's say like 100 mils. That's going to be the regular one that's left over. So now you have dead space. So the dead space is the portion of the respiratory system that has no alveoli and has little to no gas exchange. We all have that, so it's not something that you just that happens over time. So understand this. So minute volume, what we want to do is, so we need to do our respiratory rate. So if I'm breathing 12 times our tidal volume. And again, if everybody remembers what our tidal volume is, I just said it. So generally our tidal volume is about 500 mLs. So if y'all remember, we're going to take our respiratory rate times our tidal volume equals our minute volume. So it's telling me, it's roughly telling me how much volume per minute that I'm breathing. Now, why is that important to you? Well, I need to know, is it regular for them? Is it irregular? And then when you watch somebody and they're struggling to breathe, just ask them, hey, do you normally have trouble breathing like this? Do you normally have any type of lung issues, or you're a smoker? Because I promise you, made an idiot of myself years and years ago. I watched this young man, his respiratory rate was low, it looked like he was struggling. I didn't do a good assessment on the patient, and I didn't ask the right questions before I started assuming. We'll come to find out, after I started putting oxygen all over the fella and I'm doing some things that I knew I needed to do, but the man didn't need, he only had one lung. Kind of explain things. If I would have asked the right questions, if I would have made it, done a better assessment, I would have known that that was there, and not just like, oh God, you know, he's struggling to breathe. I've got to do this. I have to increase that. I should have known better. I should have asked the right questions. So if you recognize somebody that's in a respiratory problem, just ask, is this normal for you? Or are we having any type of issues with your breathing? I understand you called me because you're having trouble breathing, but I just want to make sure. So your normal rate and depth is your tidal volume, regular rhythm or pattern of inhalation or exhalation. We know what regular should be because look at us. We breathe on a normal rate and rhythm. When you count the respirations, is that normal? Is that something that's normal for them? The clear and audible breath sounds on both sides. You're going to take your stethoscopes. You're going to listen to the upper lobes. You're going to listen to the lower lobes. You're going to make sure you hear air moving in and out. That you do see regular rise and fall of movement on both sides. So both lungs are inflating and exhalation. And then you have movement of the abdomen. So that is allowing for the contraction of the mine's all over the place, of the diaphragm. Sorry, you're going to allow for the contraction of the diaphragm. Now in children, you will know what we call a seesaw pattern. Is their abdomen out, chest in, chest out, abdomen in. What they're doing is using their accessory muscles that is not allowing them, because they're not breathing normal. Those accessory muscles help push that air in, help pull that air out. So the contraction, that seesaw pattern, it's not good. When children start to crash, they crash fast. They go pretty trashy, and it sucks because now you're behind the 8 ball. So we talk about labored breathing, and it's significant signs, significant effort requiring the use of accessory muscles, again, your abdominal muscles. Breathing slower than 12 times a minute or more than 20 times a minute is considered labored breathing. Additional signs, you may have muscle retractions, you may have pale or cyanotic skin. You'll notice the blueness around their lips, blueness in their fingertips. Their skin is just like, it's not normal. Cool and damp means that they're probably starting to have a cardiac related issues. And they're in a tripod position, which means that they're leaning over and a arm or both arms are extended, trying to open that chest cavity up. So they're trying to get, so when we sit like this, there's pressure on our cavity that's restricting us to breathe. So when I lean over and I put my hand out to hang on to something, I'm trying to pull the pressure off of that cavity. I'm allowing gravity to help me breathe better. Those are your honestly, your telltale signs of inadequate breathing. And we're gonna have to do something. We can't just watch that and be like, you want to go to the hospital for that? Or you want, what's up, bro? That's our job. They called us there to do something, but we need to know how to recognize that before we start telling you how to treat it. So any one of those, the paleness, the cyanotic, cool, damp skin, we need to be doing something because it's not long before they start to crash. So, and when they do crash, you're either going to go into respiratory failure, respiratory arrest, cardiac failure, or cardiac arrest. Neither one of those are going to be good. They're all going to be hard to come back from. You have your circulatory system. The circulatory system is the cardiovascular system, is a complex arrangement of connected tubes. So we put your cardiac in there because it helps circulate the blood. We need to know that we do blood. We got to clean it. We got to make sure that we get it from having dirty blood to clean blood. In the circulatory system, as you can see, you have your arteries, your arterioles, your capillaries, your veins, and your venules and your veins. You do have 2 circuits. The systematic circulation carries oxygen-rich blood from the left ventricle through the body back to the right atrium. The pulmonary circulatory system carries oxygen-poor blood from the right ventricle to the lungs back to the left atrium. So I'm going to say that again because I'm sure y'all are going to want to write this down. The systemic circulation carries oxygen-rich blood from the left ventricle through the body and back to the right atrium. Pulmonary circulation carries oxygen-poor blood from the right ventricle through the lungs back to the left atrium. So the ventricles, the left ventricle into the right atrium is taking oxygen-rich blood and pushing it out. And then it's going to come back through with dirty blood to the right ventricle and back into the lungs and back to the left atrium. So it's pushing it, cleaning it, pushing it, cleaning it. It's a circulatory system, makes a big circle. I don't know if y'all like me, but I like my blood to go round and round and not come out because we're only allowed to have so much in our body. So I want mine to go just like this pattern right here. So as you can follow the ARES, it's going from the artery to the arterioles, down into the supravena cava, into the heart. So then it's going to make this big hook down into here, go up through the artery into the lungs, where it's dumping the dirty blood back into the oxygen has been situated. It's all for pushing the carbon dioxide out, and the O2 is enriching the blood coming back through the left ventricle. It's going to make that hook. It's just making this pattern all over again. This is going down into the lower part of the body. It's the same exact pattern. Just pushes everything through. See, got to get the blood cleaned, pushes it back out. Happens to the upper part of the body and the lower part. Now, when the body starts realizing that the body's going into shock, it will start shunting oxygen and blood to the lower part of the body, and it wants to keep it in the core. Once the blood is kept in the core, it's because that is most of our vital organs is in the core part of the body. Our legs and our feet and our knees and pelvic, that's not life issues. We can shut that area off. It's like turning the AC off in a portion of your house to try to heat and cool the center part. That's just trying to save electricity. That's what the body's doing here. It's trying to save blood by bringing it all to the core. And that's how it can also help warm and heat the body, is keeping it inside the core. So, does anybody have any questions on how the blood is pushed out to clean once it gets more oxygen and it goes back through the body? Y'all have any questions about that? Right. Keep right on. See how many. So there is 109 slides we have to totally hit. We are on 53 now. So this gives you an idea. We're almost halfway through. So we will probably see about 8:30 tonight. All right, so the heart, it is an involuntary muscle. We know it is hollow because we just saw the blood has to go through it. If it was not hollow, I don't know how we're gonna get blood through it. It has to have the valves, the ventricles, and all that for the blood to go through. It is a two-paired pump. Each side is divided into the left side is the muscular and high pressure system. We have our right side, which is our thinner and low pressure. Your atrium is the upper chamber, and your ventricles are the lower chambers. So remember, like on your left side is all high pressure. And sometimes that's where you may have a blowout, like they may have to go in there and have heart surgery because it gets weak. It's had so much pressure being pumped through there. I can't tell you an exact PSI for somebody that's asking, but at the same time as we know that there's so much pressure in there that most of the time that your upper lefts have always had the ones that have the valve issues or the pressure problems that require open heart surgery. So the heart receives its blood from the aorta via the coronary valves, coronary arteries. I don't know where I got valves from. Sorry, y'all. The right side of the heart receives deoxygenated blood from the veins of the blood. Oxygenated blood returns from the lungs through the pulmonary veins into the left side of the heart and is pumped into the aorta and into the arteries of the body. So remember the picture, how it made the loop, kind of did a little crisscross for the lower part. You can do the same thing for the upper part. It's kind of like a good figure eight, if you guys understand what I'm talking about. So valves guide the path of the blood to the heart. So you have like valves. So like one way, so the fireman here, you have one-way clapper valves. Same thing you have in your like your high-rise buildings, so the pressure doesn't come back down. Well, if sometimes when people start IVs on you, and if they tell you, be like, oh, well, it blew because it hit a valve. Well, what that is, it's your body has one-way valves too that lets blood go up. It doesn't really let blood come back through the vein. It comes through the arteries and then through the veins. So that's the reason why sometimes the vein may blow when they start an IV, or if it's just too big of a needle. Anybody that starts an IV has their own particular way of doing them. Sometimes I can advance the catheter all the way in. Sometimes I take it and I'm very timid on how I advance it, so I don't blow that vein. It's just learned over time and how to take it and roll with the punches. So here again, here's a picture of your heart. We break this down into the right and left side. So your left is your pulmonary artery. We have the purple is representing the pulmonary artery. Right here is your supravena cava. That's from the head and the upper part. Again, it's coming from down here where your lower part of your blood is. This is the oxygen poor blood. And again, it's coming from the upper part of the body, also with the oxygen poor blood. Your left pulmonary artery, which is your oxygenated blood. So this is what's pushing the oxygen throughout the body. It goes to your left atrium, your left ventricle. It makes that big loop, pushes it back out. It can go into the upper part of the body or even to the lower part of the body in a round circular pattern. Remember, this is a closed loop system. The closed loop. Same thing, firemen. When you have a closed loop system for like your fire hydrants, let's say it may be run off of a water tank on a certain area, like certain neighborhoods are not on city water, or you're out in the county and you just have a water pump to that area. It's closed. There's no way that we can just open a petcock, put more blood in and close it off when we're good and circulate it around and empty it out to get the blood out. Now, you can have that open system when you go to like dialysis that cleans your blood, because we're unable, the body is unable to clean it through the kidneys and all that. So that is an open system, like when it has to be inputted into the body to where they can clean the blood out. Hope that makes a little bit of sense. I tried to break it down so people can, I like breaking things down simple because it makes me feel better when I understand it too. So this is where it gets complicated, and I'm sorry. So right now, my normal resting heartbeat is 78. So that's my normal resting. So when I go into stroke volume, that's the amount of blood that is moved by one beat. I will say that's probably important, knowing what your SV is, not yours particularly, but knowing what the SV is in general. So you have your cardiac output, or CO, is the amount of blood that is moved in 1 minute through the body. So your heart rate times your stroke volume equals your cardiac output. So no, I'll skip that. That's confusing. And some extra notes added in the bottom. I'm gonna skip that. All right, so your electrical conduction. So we have to make the heart beat, and it's got to have electricity. Well, we can't flip the switch and turn the heart off, thank God, because I'm sure I would have made too many people bad in life and they'd flip my switch off and wouldn't turn it back on. So a network of specialized tissues that is capable of initiating and conducting electrical current runs through the heart. Electrical impulses begin in high in the artery and the SA node, and they travel to the AV node and the bundle of His. Now it's a bundle of capital HIS, and then they move through the Purkinje fibers to the ventricles. I don't expect you to know how this works, but I want you to have an understanding. And now again, when somebody asks you, which way do they go? And you're like, it goes round and round. I get that. So the movement produces a smooth flow of electricity for producing coordination in the pumping action. So it fires in certain areas, which is creating an impulse and a muscle contraction to certain parts of the heart, which makes it beat and sends it, beats and sends it, and it pumps. That's how it pumps, is certain triggers of electrical current. And if they're injured, the heart will not beat properly. And that's where you may get pacemakers put in there. You may have to get cardioverted to where your heart is in a higher rate than normal. You get into like SVT, which is sinus ventricular tachycardia, and that's anything over 250 beats a minute. That's not good. I can shock you and pray to God I can restart your heart. I can also give certain types of medications that will stop your heart, and again, pray to God that it starts beating again. I've used that drug twice and about pooped on myself each time. It's a very, very nerve-wracking drug. All right. So we're going to talk about arteries now. Arteries carry blood from the heart to all the body. So that's its job. The artery is the bigger vein in the body, and that's what you can feel in the pelvic griddle when you push hard enough. Is your femoral artery. Your aorta is the main artery that leaves the left side of the heart and carries fresh oxygenated blood from the body. Has many branches that supply the vital organs. So once it leaves, it's in a big tube, it's coming down the body. Well, it can go down one side and cross over to the other side, but if it doesn't have those branches, we're not getting blood to our hands or to our legs. So we got to figure out somewhere. So as you see on your screen, you have your different type of arteries that branches from your aorta. And as you can see, they go to all different areas, your coronary arteries, your cricoid artery, your hepatic arteries, your renal arteries, and your centric arteries. Those are all super important, and they can be stopped. They can get a blockage. It's important to make sure that they're not blocked so that your body gets oxygenated blood throughout everything, throughout the entire body. We want blood to flow because that's what keeps us alive. And if it doesn't flow, let's say to your coronary arteries, your heart's not going to do nothing. So we need to make sure that area is well functioning, so it has the proper amount of blood. Functioning well, how about that? Changing. So the pulmonary arteries originates at the right ventricle and carries oxygen poor blood to the lungs. Arteries branch into smaller arteries and into the arterioles. And again, right there, it says arterioles branch into series of increasingly smaller vessels until they connect to the capillaries. So it's like taking water from the city main. And it's a 12-inch main. So we're looking at 12 inches. I'm just making fun, but let's say that's 12 inches just to get water from the city water into a neighborhood, y'all. Well, that pipe, 12-inch main, cannot go into your house. Your house cannot manage that much pressure. So they neck it down to different size pipes that can contain and control that pressure to where then it gets into your house until it's a small 1/2 inch, 1-inch pipe. And that's how you take a shower, wash clothes. You can lose pressure if somebody's digging and hits one of the water mains. You may lose pressure. It's the same thing in your body, that it is branched down into, it's necked down into all the way down to the capillaries. Well, you got to take it from the artery, and it just keeps breaking it down to smaller and smaller and smaller. I'm over here drawing. I know y'all can't even see my finger. I'm sorry. You should have seen my little draw. I drew a little unicorn. Y'all didn't know about that. All right, so your pulse, you can palpate it in the neck, the wrist, and the groin. Now, you have to remember when you go right here, when you go to check your cricoid, you can feel it beating, but you gotta, oh, there it is. Make sure you're using 2 fingers. And I have seen this time and time again on registry when people come to me and I check them off on their skills. It's FYI, in the end, I am unable to check you off on your skills. I can't even be in the building when you guys take your final skills because me being an instructor. So you can palpate it here in the neck with 2 fingers. Don't ever use your thumb. And I've seen that time and time and time again, and I will fail somebody in a heartbeat because you have a pulse in your thumb. You go to check your wrist. It's always going to be on the outside of the wrist, right in here, with 2 fingers, and you check there. Now with the groin, you're feeling the artery. Again, I'm not going to walk up to the Sydney and just be like, oh, I'm going to check your pulse and reach to start checking your femoral artery in your groin. You'd be like, whoa, bro, what you doing? I'm having trouble breathing. Like, what are you? So understandably, be very cautious about that. And a traumatic issue, it may be important to check the neck, the wrist, and the groin because you're able to tell if the body's starting to shunt blood, or is the body pumping enough blood to support circulation in the legs. So that's important, and knowing where it's at in the groin is important. That's the reason why, like, it's in your pelvic griddle. So let's say this is your pelvic, here's your 2 legs. You may have to pull the leg out a little bit right in here. Now this is your groin, male and female. These are our groins. We're just going to say this is our groin. Here's our legs. That's a very bad drawing or description. But you may have to separate one of the legs and feel right up around the pelvic area, right about where your pants fit, and into where it dips down into your leg. You have to palpate. You have to feel around, and it is deep. So you're going to have to push. Once you find it, mark it with a marker. I highly recommend everybody carry Sharpies when you get on the ambulance to start doing your ride. We have multiple Sharpies in here. I have some over there. by our, you can see the bed. I don't know how to really turn the screen off, but I was clicking on buttons the other day and now I don't. But anyway, you can mark those areas. I do the same thing on, like, if I find a pedal pulse, which is on their foot, I will mark that too. The wrist, I'm not really going to write an X on your neck if I'm picking you up, take you to the hospital, but I note that in my report that I was able to find a radial pulse and a cricoid pulse. If there's any type of respiratory or cardiac related issue, I'm not necessarily going to feel for a brachial, which is in your elbow, or a groin, or for an artery. That's just not something that's going to work. Let's see here. All right, so here's the chart of where the veins and arteries run. You can see it's a lot. I hope it's a lot bigger on your screen than it is on mine. I'm gonna have to put some glasses on to see that. I can't read it, but here, right on this side, and both on your left and right, that is your dorsus pedis pulse. That's a pedal pulse. If I take your shoes off and I'll take your socks off and I'm trying to feel for a distal pulse, that's where I'm going to look, is your dorsal pedis. You can feel for the groin. You can see right here where mine's not defined like that, so I'm just saying. So you can feel the artery right here. That's your femoral artery, because remember, it's right here by your femoral bone. So that's why I got that. And then you can feel up here in the neck for your jugular. And then right here in your wrist, you're trying to feel for the radial pulse. That's just the breakdown of it. Now the other, God, I can't read that. I know that you can feel the brachial pulse up here in your arm. I know what this is pointing to. I just have no idea what some of these words say. Yes, I can see, but I'm blind when it comes to this size. All these different arteries and veins have big important names. But the ones that you really want to worry about is your external cricoid, your jugular vein, which is basically the same thing, your brachials, your radial pulse, and your dorsal pedis. Those are the most points that you will go to use when it comes to finding a pulse and documenting what the rate is. All right, so your capillaries. Capillaries connect arterioles to the veins. They have fine endings in the division of the arteries. Oxygen and nutrients pass from the blood cells and plasma in the capillaries to individual tissues through the vein-thin walls of the capillaries. The capillaries allow for the blood to move through them one cell at a time. It's a particular word. I'm trying to just go particular. And there's a word for it, and I can't remember. But they will move blood back and forth. But again, it's not going to be a mass transaction. It has to be one cell at a time, and it's a slow process. Let's see, veins, we return oxygen depleted blood back to the heart. They do have thinner walls than arteries, and they're generally larger in diameter. Because remember, what's it doing? It's turning the depleted blood. So it's going to be thicker. They do have major veins. The superior vena cava carries blood returning from the head, neck, and shoulders to the upper extremities. The inferior vena cava carries blood from the abdomen, pelvis, and lower extremities. And the systemic vascular resistance, which is called the SVR, is the resistance to blood flow within all blood vessels except the pulmonary vessels. Woo. What's it say on yours? So there, yeah, these are where both of them join back up at, is the join at the right atrium. Let's see. Told you, it was a lot of information in this chapter. So the spleen, what do we know about the spleen? Well, we know that it holds a ton of blood. Say it does filter it, but it will rupture. We know people that's had spleens removed, or once they've ruptured due to a blunt force trauma, let's say hit by a car, football, baseball injury, they go in there and have surgery and have those removed. When it filters out the worn out blood vessels. It has like foreign substances in there and maybe some bacteria from the blood. It kind of holds it in a pool of area. It is highly vascular and is particularly susceptible to injuries, which we said. Solid organ located under the rib cage in the left upper part of the abdomen. That's just where it's filtered and it holds. Again, it's not, I mean, I don't want to say it's not needed, but at the same time, it can be removed and the body can still function. So the body does have different composition. We talk about how it gets its viscosity. It's the same thing as like you have different viscosity of oil for your trucks. But the plasma is a liquid portion of the blood. It does contain water, proteins, oxygen, carbon dioxide, nitrogen, and nutrients. Sorry. Red blood cells contain hemoglobins, which carries oxygen. Your white blood cells play a role in the body's immune system that fights. That's the reason why when they check your blood, they'll say your RBC count is high or low, and they may say your red blood cells are high or low, but they always call it RBCs or WBC. And then your platelets is essential for the initial formation of blood clotting. So like I carry too much red blood cells and platelets, which I don't know why I've decided to start making that, but I can donate up to like 1.5 pints of blood every 6 weeks. They've tested and told me that's what I do. And then also for my platelets. So if I were to get cut, my blood would thicken and create a clot faster than normal. So that's the reason why they urge me to donate blood every 6 weeks. And then also they want me to give platelets, not plasma. I don't know, this is gonna be my first time to give platelets when I go home. So I'm not real sure how that, I mean, I know how the process works, but not real sure what we're gonna be doing there. I know it takes a while for that to happen. So blood pressure. So the pressure that blood exerts against the walls and the arteries, that's where your blood pressure comes from, is your systole is when the left ventricle of the heart contracts. It pumps blood from the ventricle to the aorta. So your diastole is when the muscles of the ventricle relaxes and the ventricle fills with blood. So it'll be your systolic and diastolic blood pressures. I don't want to go too fast. Before I cover that. Okay, here it is. So your systolic is a high point and your diastolic is a low point. So somebody tell me which one is the top number versus the bottom number. Anybody want to guess? There's got to be somebody that knows. Y'all paying attention or doing something else. All right, so your systolic blood pressure is always your top number. Your diastolic is always the low number or the bottom number. So your blood pressure can be obtained using a sigmometer. I don't know if I say this right. Sigmometer. That's what a blood pressure cuff is called. Systolic blood pressure is a high point wave is contracting. Diastolic blood pressure is the low point of the wave as the heart is relaxing. The blood pressure is expressed in millimeters of mercury. That is probably a test question. It is MM capital HG. Sorry, Nikisha, I think there may be a delay. My computer may be going super fast and versus transferring because all my information that I talk and internet has to go all the way into the beach and then it shoots back out. I apologize to all y'all. It's okay. I'm sorry, y'all. It could be my fault. You know, with me here, we're gonna. I have to find this on my screen now. All right. So functions of blood. What does the blood do for us besides transport oxygen back and forth? Which we know that it helps fight infection because of the red blood cells and the white blood cells. The white blood cells increase, and that's what attacks the infection. It does transport carbon dioxide. No, Michaela, it's probably me. The computer is lagging. So remember me being offshore. So all my data travels into Houston and then it travels further out. So we have really good weather tonight, unlike the other day. So that is probably why there's a low lag and it's probably on my end. So when the data finally hits it, it speeds up and getting out to you guys. So back to the functions of the blood, it does control the pH of the blood. So it's going to either make us more acidic or more of a base. Transporting waste and nutrients, so it's got to go somewhere. So once we use it, it gets back into the bloodstream and it transfers and dumps into like the kidneys, the lungs, the oxygen we breathe out, or waste that we can push it out through our GI tract. And it also helps with coagulation and clotting. Makes us, if we cut ourselves, the blood is what helps make that clotting factor, and so we won't bleed to death. Some people have issues with that and are unable to clot normally. So that's where they have to be very careful. And those are like your hemophiliacs. They're very cautious about things because their ability to clot is kind of not there sometimes. Your sympathetic nervous system is responsible for your fight or flight response. That is important for you guys to understand and know, is that your sympathetic nervous system is responsible for your fight or flight. Probably going to see that. This does send commands to our adrenal glands where it drops that load of epi, where it does that dump. Your epinephrine, adrenal gland, or norepi are secreted to stimulate heart and blood vessels. So that's what gives us that that rush of energy, that dump of just, I'm here to save the world, and you're like, okay, I'm good, the emergency's over, and then you get real sleepy, you get real tired because your energy level has just been consumed really, really fast. Well, I gotta find something. All right, so we got that part. All right, so the sympathetic nervous system is responsible. We talked about that. Where is that? All right, so the sympathetic nervous system is the heart and blood vessels have alpha adrenic receptors and beta adrenic receptors. Adrenic means related to the adrenal gland where epinephrine and norepinephrine are made. So your alpha adrenic receptors are found in blood vessels. And it's when stimulated, blood vessels contract. Beta adrenic receptors are found in the heart and lungs. When your beta 1 receptors are stimulated, the heart and force of the contraction increases. When your beta 2 receptors are stimulated, the bronchi in the lungs are dilated. Certain patients can be put on beta 1, beta 2 and medications that can trigger certain things. Like if they're on a beta 1, we know that it's going to go stimulate the heart. Beta 2 is going to stimulate the respiratory system. So if you happen to see that, like they're on a beta 1 or a beta blocker, well, you need to know what type of beta blocker, if it's for the heart or the lungs. So your parasympathetic, it causes the heart rate to slow and beat more weakly It drops you down into a Brady rhythm. So you have your bradycardic, which is your low, very slow in. You have your normal sinus, which is what majority of the population walks around in life in. And then you have your tachycardia. You have several different rhythms that are encompassed in each of those. But most of your people that walk around that are parasympathetic nervous system drops their heart rate anything below 60. The parasympathetic and sympathetic nervous systems balance each other out. So it can help with your heart versus going up versus down. It makes that buoyancy level in your body. Baroreceptors sense pressure in the blood vessels. They are found in the aorta and the cricoid bodies. And they cause stimulation of the sympathetic nervous system and the parasympathetic nervous system, and it helps adjust your blood pressure. So if the body realizes like, oh, your blood pressure is getting super high, these baroreceptors start dumping to either assist in bringing it down. People that are put on medication need more assistance in getting that. I take a blood pressure medicine. 40 again threw me off the loop, but it had created an issue to where I needed assistance in bringing my blood pressure down. Tell you what, guys, let's take a 10-minute break. We got about 30 more slides once we get done with here. So we'll take a 10-minute break and we'll be right back. So I'll see y'all at 12 after 8. All right, everybody. I know y'all are so excited. We're gonna get back on this. I need to do this. All right, so we're gonna talk about the skin, the anatomy of how it's broken down. There are two layers. We're gonna talk about the epidermis, which is the superficial. It is sealed from what? From a watertight protective covering. It's composed of several layers of cells. You have your terminal layer, which produces new skin all the time. You have your stratum corneal layer. I just badgered that name, just letting y'all know. Which is the superficial, it's a surface layer of dead skin. Then you have your skin cells are constantly being replaced. So then we break it down into your dermis, which is the deeper part. So you have, remember your epidermis is up top, superdermis, dermis is down low. And the dermis contains a special structures of the skin. So we have sweat glands here. They produce sweat, obviously helps cool the body off. You have your subcutaneous glands secrete sebum, which provides waterproofing and softening. Hair follicles are small organs that produce hair. Blood vessels provide nutrients and oxygen to the skin, the mucous membrane, and below the skin lies subcutaneous tissues, a layer of fat that serves as an insulator into the energy reserve. So if everybody has seen a cut, you've all seen it, where you're like, oh, we got it down to like the white meat. Well, that's the fatty part. You can see it, all of it. That's a pretty deep cut if you see the fatty layer, because you've cut through the epidermis and dermis. It's still stitchable, but that's one of those things like we stitch out here, but it has to be like there's weather's bad or something for us to stitch it. Sorry, I had to change the background. It was bothering me. I couldn't do it no more. I finally figured out where it was. So knowing the depth of it, if it's just a superficial cut, or it's a deep cut, or it's all the way down to the fatty layer of the muscle, of the skin, that's something that we need to know and why. Here's a picture of it that breaks it down into the different layers, which we know here's our hair. We talk about a pore. This is the epidermis right here. The dermis, subcutaneous, breaks it down into the muscles, and the fascia right in here is the little white part of the fascia. Subcutaneous fat, that's where you're gonna see the white meat. Everybody's seen those big nasty cuts. A lot of times when somebody like a boxer, MMA, or just a regular fight is gonna get it cut down in here to your dermis, you may have a little bit of epidermis cut. But majority of the time that they're gonna be those deep cuts, it goes down into the dermis. A lot of times when it's cut super deep down into here, you may not feel it as much because it's cut through and deeper than the nerve runs. I've seen some cuts from a knife, obviously, that was cut all the way down to the bone, and you were able, I could have stuck my finger in there and touched the bone, but I opted out of that. So, and then the guy was like, man, it really doesn't hurt that bad. It hurt more as he had that fight or flight mode started wearing off, and he was able to be like, oh, my arm's starting to hurt. Man, this is starting to hurt really bad. So, but anyway, that's how it's broken down here. As you can see, what's broken into the subcutaneous gland. It's up in here. Here's where that's where like your sweat comes from. Your pores, your sweat comes out of here. Your blood vessels, it keeps the hair follicles alive. So the different layers of the skin is kind of neat, kind of important. And then we break it down into the three major functions of the skin, which we know it does protect us. It regulates temperature, and it transmits information from the environment to the brain. Be like, oh, that's cold. That's a sensation field. So we know that when it starts transporting the information, that put long sleeves on, cover up, put a jacket. And it's not just because we read it on our phones. We know because we've been in that air. We know that 66 degrees is cold, and we want to cover up to stay warm. We talk about our gastrointestinal, which is our digestive system. It's your abdomen. When the abdomen contains major organs, it talks about your digestion and your excretion. So we break the abdomen down into 4 quadrants. So if I'm looking at my abdomen here, here's my belly button. I'm going to draw a line straight down and then straight across. So that divides it into 4 different categories. We have our right upper quadrant, so it's RUQ. your lower upper, so it is a right upper quadrant, left upper quadrant that is supposed to be left instead of lower. Then you have your right lower quadrant and your left lower quadrant. That is the different quadrants of the abdomen. So their abbreviations are RUQ, LUQ, RLQ, and LLQ. So instead of having to write, I'm sorry, Pastor Gould, I just saw it. There's your three main functions. Let me know when you get that. I apologize. No, there's a delay, so that I try my best to do it. All right, so all good. All right, so remembering these abbreviations again is better. Because when you write your report, you can be like, oh, the LLQ was the area of pain. As I assessed the other three quadrants, no other pain was noted. The small intestines, the pancreas, the large intestines, the urinary bladder lie more into one quadrant than the other. The kidneys and pancreas lie behind the abdominal cavity, which is your retroperitoneal, which means it's in the back. So again, these are important. You will hear these later on as we go throughout the chapters on which one is where. Here is a diagram of the quadrants, and you can see how this line goes straight up the body, cuts right across right here at the waistline. So you see your large intestine and your rectum. It's going to be on one side. They break it to your appendix, small intestine, your gallbladder, your liver. We kind of stop it right here at the bottom of the rib cage most of the time. And then your spleen is going to be kind of the base of the spleen is going to be in your left upper quadrant, because it is left, because remember, this is the patient's left arm. It's not just because I'm looking at it. Sorry, I'm trying to look at my picture instead of looking at the camera. So my right hand is their left part of their body. That is very, very important when you talk about documentation, that you get it on the correct side. Sorry, I was almost confused myself there. Let's go over some other parts that are attached to the digestive system, that what we know. All right, so I'm gonna break this down and tell you what's into each section. So the mouth consists of the lips, cheeks, teeth, and tongue, the hard and soft palate, the salivary glands. So you have two sets, one on each side of the mouth and in the front of each ear. Saliva is approximately 98% water, 2% mucus, salt, and organic compounds. Oropharynx is a tubular structure that extends from the back of the mouth to the esophagus and trachea. I tell you what, I want to see if I can do this. This may help you guys. Copy. All right, so I just pasted that, copied and pasted it in the chat. So if y'all want to try to copy that, because this is important too. Your oropharynx is a tubular structure. We talked about that because we know that's where encephals our vocal cords, where we put the tubes at. That's where air comes in and out. The esophagus is a collapsible tube about 10 inches long. Extend from one end of the pharynx to the stomach. Muscles in the wall of the esophagus propel food to the stomach. Stomach is a hollow organ in the left upper quadrant. That may be important. It's a hollow organ in the left upper quadrant. It receives food, stores it, and provides for it movement to the bowels. Excuse me. The pancreas, that is a flat, solid organ that lies below and behind the liver of the stomach. Remember, it's the retroperitoneal, what we talked about a second ago. Two portions, the exocrine and the endocrine. The exocrine portion secretes pancreatic juice containing enzymes that aid in digestion of fat, starch, and protein. The endocrine portion, islets of the Langerhans, produces insulin and glaucoma. Glucagon, where did I get glaucoma from? Glucagon. Ooh, that was special. I told y'all these words just throw me out for sometimes. So you need the endocrine part because that's the endocrine system, and you go see an endocrinologist when you start to have blood pressure problems, or not blood pressure. You're starting to have sugar problems and they can't figure out why. You should see an endocrinologist. So because it messes with the pancreas, and maybe the pancreas is not producing enough insulin. You can become insulin dependent diabetes. You can be dieting. So all those different things will help you. Let's see. All right, so your liver, it is let's see if I can do this again. This is probably going to be very helpful for you guys if y'all trying to write something. All right, so the liver is a large solid immediately beneath the diaphragm of the RUQ, and it extends to the LUQ. The liver has many functions. You know, some people in their adulthood have badgered their liver, some of the alcohol, I don't know. It just filters harmful substances. It's forming the factors needed for blood clotting and normal plasma production. It does store sugar or starches for immediate use by the body for energy. Then you have a bile duct that's in the liver. So the bile duct connects to the liver and to the intestine. It carries bile from the liver to the gallbladder where the bile is stored to the duodenum. Now again, you can have your gallbladder removed and you don't really need that portion. I've had that removed. Mine just quit working, causes a lot of pain. So your small intestines, this is a major hollow organ of the abdomen. It produces enzymes and mucus to aid in digestion. It is composed of the duodenum, duodenum, and the ileum. The large intestine is a major hollow organ that consists of cecum, colon, and the rectum. The major function of the colon is to absorb 5 to 10% of digested food and water from the intestines to form solid stool. It's a lot of information right there, y'all. Super lot. So our appendix, a 3 to 4 inch long tube that opens to the cecum, is the first part of the intestine, in the right lower quadrant of the abdomen. It may be easily become obstructed, inflamed, or infected, which creates a appendicitis. All right, so here's your rectum, the last part of it. A large hollow organ adapted to hold quantities of feces until it is expelled. It is terminal. It's at the terminal end of the anus. The sphincter controls the escape of liquid gases and solid from the digestive tract. So now y'all just learned something else. So your sphincter muscle is what helps push out the feces, and it controls your farts. It's really the best way to put it. So if you have a weak sphincter muscle, you might poop or poot all the time. So that's the reason why they say, you know, ooh, a sphincter muscle leaked. Now, again, that may just be showing my generation and my age, but that is also what it's related to. And when somebody says that. Here, let's talk about the digestive system, which we know that the food has to be broke down by a weight. Well, we can't just swallow food whole and it turns around and comes out. Some food is digested in the body and some of it is not. Corn and pepper are some of those that are not digested. Saliva helps break that down. You have, what's it say right there? Enzymes are added to food by the salivary gland, stomach, liver, pancreas, and small intestine. So what that does is it converts the food, right on your screen too, into basic sugars, fatty acids, and amino acids. These basic products of digestion are carried across the wall of the intestine to the liver and processed further and stored into transported to the heart. So your heart's got to have some nutrients, and it's brought down through the food that you eat. It's circulated via blood throughout the body, which we got to carry those nutrients, just like we got to feed our body. not only are we trying to get in from like food and drive and push on, that's our drive. We've got to have the sugars, we've got to have the nutrients that from our food that's broke down again by the stomach, liver, pancreas, and small intestine to help put nutrients into our body. That's why it's important to make sure you eat and you eat healthy and not just fatty foods. Because then you get like the fatty heart, you get more fat, your heart gets lazy. It's just one of those that start swelling. Elements of the lymphatic system. I'm gonna hold this for a minute so y'all can write that down. We'll talk about it. So some of the things that are imposed in there, you have your spleen, your lymph nodes, you have different lymph nodes throughout the body. Your lymph vessels, your thymus gland are other components. There's going to be more on the next slide that talks about that. Let me see what it says. Not as much as writing this down. These are some of your elements of the lymphatic system. So those are going to be there. All right. So the lymphatic system does support the circulatory system. It carries oxygen, nutrients, and hormones to the cells and waste products from the metabolism away from the cells to be excreted. So we got to get rid of the trash. We put new trash in, we got to get rid of the dirty trash. The lymph vessels form a network throughout the body, serve as an auxiliary to the circulatory system. So it can help move things. The lymph nodes are tiny oval structures that filter lymph, and it helps rid the body of toxins and other harmful materials. So if your lymph nodes get swollen, it's one of those you're like, oh, I'm sick. You can feel in here, right underneath your jaw. That's kind of one that's important. Yeah, kind of squeezing on it, as you can tell. But you can tell if these lymph nodes in here get swollen, that sounds like when you go to the doctor, they feel around your lymph nodes and check them. That's to see if there's any swelling, because that's going to indicate that there's an infection. So it helps. If they get blocked up, then the infection is not able to pass through the body and be passed out. So there may be toxins that are built up. That's why you get put on the antibiotics. You may get an oral or an injection to help speed that process up. So our endocrine system is a complex message of control system. It's like a computer board that just tries to tell you all these different things. Thank God it's not something that we have to control, because we would literally never be able to go anywhere. We're like, oh, we got to do this. I got to make sure my body knows this. I got to constantly think about that. Well, a lot of us would probably end up dying, and I conclude myself, because I would forget about something. So the endocrine system is a complex message and control system that integrates many body functions. Endocrine gland releases hormones directly into the bloodstream. Each endocrine gland produces one or more hormones, and each hormone has a specific effect on some organs, tissues, or process. Here's a pretty picture of all the different glands. So we know that these are our ovaries and our testes. That's one of the ones that control sexual parts, the rebuilding, the birth parts. We have our adrenal glands on both of us here. We have our thyroids. Your thymus, as y'all can see on your screen, is not active in most children. Pituitary gland, men, that's the one that helps produce your testosterone. Your pineal gland, your hypothalamus. So these are the ones, your parathyroids, that's the ones that you can feel when you're up in here and trying to make sure that you're not swollen. You're not gonna really be able to feel the rest of those. Your pituitary gland is really, really small. It's this little bitty gland that's right there on the, and they can only check that through a CT or MRI. They can look at it if they inject fluids and all that. They can check it in different ways. But that's the breakdown. More into the, we're fixing to dive off into the reproductive systems here. All right, so we're gonna talk about the urinary system. Hey, we gotta get rid of it. It helps push out urine in some form or fashion. It does control fluid balance in the body. It filters out and eliminates waste. If it's something that we can keep in the body, like water that we need that's been filtered, we're gonna keep some water in the body, but at the same time as we'll push out what we don't need. And again, it helps control the pH of the body. That is important because we don't want to be too acidic. We can be super sick, but we, at the same time as we don't want to be on the opposite side of the table till we're trying to add more acidity to the body because the urinary system controls it. You can get a UTI, urinary tract infection, and then from that you can become acidic, and you can become septic and die too from just a urinary tract infection. So staying on top of those things are very important. If you notice that you're not urinating like you're supposed to, or as common as you are, that's when we start worrying about it. Here's a picture of a urinary system. We talk about our kidneys here. We go down into our urethra and then our bladder. Not everybody, when everybody's like, oh, you must have a little bladder. Well, our bladders are based off our body size. So majority of us have about the same bladder. It just depends on what the neuros are transporting to the brain. It's like, I gotta pee right now, or I don't. Over time, this does shrink, and that's the reason why you get people to go to the bathroom a whole lot more. So it opens up into the urethra opening. The prostate gland is right here, and then you go down to the urethra, the penis, and the external urethra opening. So our kidneys are broke down. We'll talk about the females in a second, I think. Yes, it's coming up. All right, so the males contain the testes, the epididymis, the vasa deferna, the prostate gland, the seminal vesicles, and the penis. The females are gonna, I mean, with some obvious points taken out, we're gonna all have the same parts that do different things. Here's a picture right here as we talk about its functionality. The scrotum, this is where your sperm comes in. Here's your prostate gland, which is checked through the rectum. It's high. Your pubic bone. So these, in females, this is where you protect the baby, their kidneys, their bladders. Those can be broke pretty easily in certain positions. If they ride, seat belts can do the same thing. Scrotum, we have the penis, the testes. Here's the epididymis. It's down in here into the testicles. The urethra, the prostate gland, which is what we showed over here, the vasa deferna, urinary bladder again, and urethra. It's not complicated, but it's just a lot. When you look at it, you're like, I don't know. I'm not asking you to label a diagram, but at the same time is know what is in the males versus the females. We talked about the males. Let's look at what the females. So they have the ovaries, the fallopian tubes, the ureter, the cervix, and the vagina. And then here's a picture if some of us don't know. There's your ovary. These are the ones that that's basically their testicles that are inside. That's the ovaries. They separate them there. Your fallopian tubes. You can also have a pregnancy that a baby can be here instead of where it's normal supposed to be, and that is super really painful, and that can only be fixed by surgery. Your ureter, your cervix, and your vagina open. And this is the angle that you're looking at the buttocks right here. This is the rectum, goes up into the colon and drops all this. It should be, normally it's packed with feces in this area. Sometimes once you get emptied, it's further back up into the system here. There's your pelvic bone that we were trying to talk about on the male. Not a whole lot of difference. It's just they're in different parts of the body and they're named different. They have the same, like the ovaries and the testes, and they're the same function. They're just in different places and have different names, but they do the same process. We know the life support chain. Cells are the foundation of the human body. All cells of the body require oxygen, nutrients, and removal of waste. The respiratory and circulatory systems are the carrier of these supplies and waste. And if interference occurs, cells become damaged and die. It's like us. This doesn't happen, we become damaged and die also. We talk about here, cells use oxygen and nutrients. Then we have our adenosine triphosphate, which is our ATP. It's used in energy metabolism and storage. The ATP is very important. The more you learn about that, if you move on to like an A&P, that's when you get into college and start doing your A&Ps, you'll learn about your ATPs. Cells switch between anaerobic metabolism when the oxygen is limited. Lactic acid is damaging waste produced by this process. And as lactic acid and other waste accumulate around the cells, the air becomes toxic and cells die. So that's the reason why we worried about the pH in the body is once it starts getting too acidic, it can kill some of the cells. And then we start getting into the anaerobic metabolism and the lactic acid builds up. We're on a downhill cycle trying to catch up once this patient gets into the hospital. Now, again, we're not going to be able to recognize some of that into the EMS side. When we get onto the streets, it's just knowing how things function and work should allow you to treat them better. So we know how the movement of oxygen is done. We know that it moves on one side, it takes the nutrients, it takes carbon monoxide, dumps it, cleans it. We talked about what controls the pH. The body, it spends a large amount of energy to maintain normal pH. The reason why sometimes you get super thirsty is because the body's, it needs the absorption of that water to help control the pH in the body. Let's see, the rest of this should be just not too traumatic on us. Talked about the pathophysiology, and that is the study of functional changes that occur and when the body reacts to a disease. We're going to increase our white blood cell count because we know that, oh no, now we're getting a toxin that's creating us sick. We can become hypoxic or hypocarbia. Hypoxic is the decreased level of oxygen in the blood. Hint, hint, hint. Hypoxia is decreased level of oxygen in the blood. Hypercarbia is elevated level of carbon dioxide in the blood. And since I like y'all, I'm going to do this. Drop that. I'll give y'all some notes in there. The FYI on which one does what. That's in the chat. All right, so factors that impair ventilation. You have a blocked airway. You have impairment of the muscles. Maybe the neurotransmitter's disease. It has trauma that's been caused. Airway obstruction. Maybe they have severe asthma. And then a drug overdose. We know trauma to the chest wall or other allergic reactions. So let's break it down the easiest. So allergic reactions. We know that they start having the closing of the airway and they start having trouble breathing. Give them epinephrine, as is that fight or flight mode, to dump it open. Rodney says, so would hypoxia be like a low blood oxygen level, kind of like a pulse ox? All right, so if I put a pulse ox on you, if you know what that is, that's a little machine that goes on your finger, tells you how much oxygen's in there. You will be able to tell if they're hypoxic if they're below 90%. Anything below 93, 92, I can intubate. I can supply them extra oxygen. When they become hypoxic, that hypoxic drive kicks in, like we talked about a while ago, trying to build that extra oxygen up. But you will be able to see the hypoxic level, like the low pulse ox, because the number's starting to get lower, and it'll pick it up. That's the reason why a lot of these fire services has resulted into using finger probes, is so we can say, oh, do they need oxygen or not? Well, I'll tell you right now, I'll give everybody in this class oxygen because it's easy, it's cheap, it's free. Let's put you on a mask, let's put you on give you some oxygen. I don't care if you're carrying on a long conversation and you say, I can't breathe. All right, I can fix that because it's a mental thing. All I got to do is flow some air through there and you feel it on your face and you take some deep breaths, and I feel so much better. How about, look, since it helped you out a little bit, let's go see what caused you to get shortness of breath. Let me take you to the hospital, and it's a trust builder. That's the reason why I like using just oxygen. I'll give it to anybody. It's not going to hurt them. So we drop the epi into them. So that fight or flight mode helps with that allergic reaction. It helps increase the body to fight against that, and then now we're able to try to help breathe. Now, talk about asthma. People have their inhalers. You carry them around. inhaler. We can help them take those and help them use that and the EpiPen. One is we need to make sure that it's theirs and it's of the right dosage. Now, I can't just walk up and go psst, as the EMT basic, but I can do assisted delivery. I put it in your hand and I wrap my hand around it and I help you push the button, where'd that come from? That way that you did an assisted delivery. Because if you give them, let's say you give the EpiPen, you're providing a medication and you don't have the proper training or the ability. But if you help the patient put it in their hand and help stick their leg, that's okay. Y'all debate on that. Let y'all figure out why that sounds crazy. All right, some other factors that impair respiration: change of atmospheric pressure, which we know that increasing, let's say, like all these people that train to go do the Alps, the Swiss Alps, all these high mountains, they take time, that like they have to do oxygen depletion training. They work on these different things. High altitudes. Y'all know I'm from Mississippi, so we normally average anywhere between 200 to 600 feet above sea level. So we're pretty low compared to the rest of the United States. Not like Louisiana is a lot lower, but so when I went to Afghanistan the first time, I was like, I was struggling to breathe about the first 30 days. It took me a hot minute. It takes your body normally about 2.5 to 3 weeks to kind of get adjusted. Because I'm at 6,000 feet now. I wasn't used to that. I wasn't ready. So when I came home, I actually bought a altitude mask, and that's how I worked out every day. I put the mask on, I would train with it, I would run with it up and down the streets. I get on the elliptical to train my body to operate at a different level of oxygen. Now, when I came home, I had more energy than you can imagine because I was able to breathe so much better. I had no pressure on me. Those high altitudes affect the body because it doesn't allow for the gas movement, and it's a struggle to breathe. You take somebody like myself and take me back over there, it's going to take about 2.5, 3 weeks for me to get used to it. Like going to Colorado, several of my friends just got back. They're like, dude, for like the first 2 days, man, I just couldn't breathe. It wasn't something serious, but you're changing of an altitude and an atmospheric pressure. So it's the same thing with diving. When you dive, you have to make buoyancy stops because it's an atmospheric pressure. Every 15 feet, you have to stop and allow your body to adjust, to that pressure so you don't create the bends, which is that's a whole nother section there. All right, so ventilation perfusion mismatch. So the VQ ratio describes how much gas is being moved, especially through the lungs, and how much blood is flowing around the alveoli. So a mismatch occurs when one of the two variables is abnormal. Pulmonary embolisms preventing blood flow. So you'll hear them called PEs also. Edema inside the alveoli. And when either the V or the Q is impacted, respiratory compromise can occur. All right, so pulmonary embolism is a PE. It's when oxygen gets trapped in there. And you can tell when that happens because if somebody dies of a PE, most of the time about nipple level up, it's going to be super purple. It's going to be blue. It'll have a lot of pooling of the blood. And that tells you it's an indicative sign that they had a PE. So edema is swelling around like the ankles. You can have your fingers swell. We have, like, every time we fly out here, there's a couple of guys, and myself included, that like my ankles swell for unknown God reason. I've never had that happen before. But it's because when we take off, we climb it to anywhere between 6,000 to 8,000 feet to fly out here because it's an hour and almost a 2-hour flight. Thank God we're changing the airports when we go back in. So after my next rotation, I'll be flying like 45 minutes. We won't have to go as high. So that can create edema. So edema around the lungs and all that can create resistance and just not allow you to breathe because that pleural space now has fluid impacted on it. So it's kind of like having trouble breathing. Not personally, but you can actually hear that edema in the lungs when you listen to it. I say it's pretty cool, but at the same time as you got to do something to help get that off. So effects of respiratory compromise. So we know the oxygen levels are going to fall, and like Rodney pointed out, we're going to see that in that hypoxia, and we can see it on a pulse ox. We know the respiratory rate's going to increase because the body has another drive to breathe more to try to get that oxygen level comes in. The blood does become more acidic. The brain sends commands to the body to breathe, and it's like, hey, bro, you need to breathe right now. So blood oxygen levels will begin to fall. This will cause the brain to issue the further commands. Decreased oxygen levels will force cells to move from the aerobic to the anaerobic into the metabolism. So it changes the body to operate with less oxygen and to be able to increase, still be able to do the same exact thing. So shock. Almost done, y'all. Bear with me. Bear with me. I know this is our first long night, so bear with me. We'll have many more to go. So shock is a condition in which the organs and the tissues receive an inadequate blood flow of our oxygen. It's got to be both. So the body goes into shock. It's an impaired oxygen delivery causes hypoxia, which leads into anaerobic metabolism. You have your lactic acid buildup, and your organs start to dysfunction. They can either start to shut down, or they can just be go into a drive that is just not normal and it's not good for the body. Shock is categorized in several types depending upon the cause. We'll discuss that in another chapter. I mean, I can go there if you would like, but we're going to look about another 2 hours to talk about shock. All right, so the effects of shock. So it is similar to the effects of respiratory compromise. The level of oxygen supplied to the tissue fails, starts to drop. We have cells engaged in anaerobic metabolism, resulting in a lactic acid production, which we already know that's not a good thing. The baroreceptors detect decreased blood pressure, problems, and they initiate the release of epinephrine and norepinephrine, because now we have to control the blood pressure because there are some issues that are going on with the body. The heart rate does increase, the heart beats more forcefully, and blood vessels constrict. So now there's more pressure, and I call it head pressure because remember at the top valves are the ones that have the high pressure of the blood pressure. So now you have more head pressure, and you've got to go somewhere. Instantaneously, fluid moves into the capillary. So now I'm pushing fluid from the internal of the body that's moving to the outside. I need to off some pressure somehow. So you're going to see swelling. You're going to see the edema build up into the limbs, which is, again, not the best thing in the world to see. So now we're on impairment of cellular metabolism. This can result into metabolic acidosis. It does require more energy than when using the glucose or fuel. So again, once this is done, the body's going to be like, oh, I'm so tired. I don't know what to do. A lot of times your runners will get that runner's high. And when they crash because all that energy is being used. You have the decreased ability of blood flow to effectively carry oxygen to the cells. Decreased function of the oxygen within the cells. And the brain cells cannot use alternate fuels. If the supply available of glucose is drastically decreased, the brain cells will quickly become damaged or die. And that's where you can see some brown spots upon the skull when they do the brain scans, is because that area is shaded and it's just dead. It's got a lot of blood in there, but it's dead. It has no more function. The cellular injury up to a point may be repairable if normal tissue is performed, normal perfusion is performed. When irreversible injuries occur, no treatment will help. So here's a way to think about that. When we go to somebody that's in cardiac arrest, the faster that we can provide CPR and the faster that we can shock them, the better chance of life they have. I'll start off with 100% and we all go into cardiac arrest. If one of us is affected 20 minutes later, I have lost ultimately 20% of function of my body. So if you catch me on you start working on me on 20 and you don't get me back to 30% in 30 minutes, I've now basically lost 30% of the cells, the brain function, and there's a lot of other cells that will die. So because it did not get the oxygen, it has not had the blood, it has not had all those functions that it requires to continue life. So it had to stop the blood flow because the heart's not beating. There's nowhere for it to go. So it just sits there. And that's where you start to have brain functions and brain. When people say that they are in the hospital, they are brain dead, there's no electrical current going through there. And there's a lot of tissue that has died. You can't get that back. It's traumatic, it's sad, it's upsetting, but you knowing that you're like, I can't. Or I don't want to say that without going there. I hate talking about sex, religion, and politics. It's one of my things that I really just don't talk about because it can get very traumatic and people get their feelings hurt. And I just like a good conversation. But sometimes we can't save everybody. We only know so much that's out there. We can't be full of all the knowledge. We're just EMTs and paramedics. We don't have a surgery room in our ambulance. So we do our best in trying to understand the body so we can move past it and try to work and try to make it better. I know I've blown your mind tonight. I know y'all are all probably like, I don't know what to do. So that's the end of class. Does anybody have any questions, concerns, problems? I'm sure there's a lot. Does anybody have anything y'all want to address with anybody? You want to unmute? You're more than welcome to, and we can talk it out. Or if there's some of you that are just like, I just want to go to bed. I get it.
I guess.
Go for it.
It's not pertaining to this, but it's pertaining to the I can't even remember what it was called. I was looking at the assignments that's due tomorrow. I can't remember what it's called, but it's due at 9 o'clock tomorrow. Hold on.
Not due then. It just opens.
Oh, it just opens tomorrow. Not the quiz, but I'm talking about the assignment.
Opens tomorrow. And
what is it?
you have to read it.
Oh, okay. I got you.
All right, has anybody else got any questions? Andrea, I appreciate it. I'm sorry. I know it's a lot. I hope that I broke some things down and everybody kind of understood some stuff. So I'm not gonna hold y'all. I will let y'all have the class code. And there it is. If anybody, before y'all bow out, can tell me where that code is, I'll put you on my favorite list.
BR 549.
Can anybody tell me where that code is from?
Baton Rouge?
Nope. I'm showing some age right here, guys.
Band.
I didn't hear you, Shelby.
Is this a band?
Okay. I'm gonna let y'all ponder on that. Y'all can send me a message on Discord if y'all figure it out. Oh, I'm gonna say it that way. It's oh. All right, folks, listen, I hope y'all have a great night. I'm gonna hang out here for a little bit, turn the camera off and mute it. So if y'all have a question or anything else, y'all just let me know. But y'all have a fantastic night, and don't forget your test opens at 10 tonight, y'all. See y'all later.